Laryngeal cancer now. Risk factors, smoking, any form of tobacco use, okay? Whether it's a pipe, you know, they really emphasize pipes and that sort of thing too. A lot of people think, well, I'm not smoking cigarettes, so I'll smoke a pipe. That's not as bad. Yeah, it's all bad, okay? But also when you combine the smoking, the cigarettes or whatever with alcohol, that makes the risk for laryngeal cancer go up, 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 big time, okay? Also, other things, voice abuse, chronic laryngitis, industrial chemicals, all right, like in having inhaled chemicals, that sort of thing. Now, the voice abuse, that's somebody who maybe talks a lot with their job. I know a few years ago when I was doing 8 weeks of classes in a row and nonstop and 5 days a week, I got vocal cord nodules. So I had to cut back and start showing some videos during the day to break it up because that was a risk factor. All right. Now then, signs and symptoms. Hoarseness, difficulty swallowing, burning, like when they swallow things that used to not burn their throat will burn, sore throat, swelling in the neck, loss of speech. That's vocal cord involvement there, isn't it? No early signs. Mouth sores, lump in the neck, color changes in the mouth or tongue. The patient may say their dentures do not fit anymore, and then unilateral ear pain too. That's the tumor, maybe causing pressure on one side. Diagnosis, well, they may do a laryngeal exam, or they may do an MRI. They can do a laryngeal exam in the office and look at your vocal cords. Have any of you ever had that done? That is scary, okay? Because they will grab your tongue with a 4x4 and you will be surprised just how far out your tongue will go, and then they'll put a mirror in there and look at your vocal cords. It's not pleasant, okay? Treatment, surgery, well, total laryngectomy. Now let me emphasize something. In the hospital, there's lots of different types of laryngectomies, partial, subglottic, and in your med-surg books, they'll go into details about all the different types of laryngectomies, okay? I'm focusing on a total laryngectomy. That's removal of the vocal cords, the epiglottis, and the thyroid cartilage. Now, I want you to point to your thyroid cartilage. Anybody know where it is? Look at you, you don't even know where it is. It's up here. It's these two flat pieces of cartilage up here. You don't need them. Let them go, okay? That's part of it. They get rid of the thyroid cartilage too. Now, out of those three things that I have listed there, which one are you most concerned about losing? I heard vocal cords because she's scared she's not going to be able to talk anymore. But you better be most concerned about losing the epiglottis because that's what covers your airway when you swallow, so you won't aspirate. Now, since the whole larynx, remember this includes the epiglottis, is removed, this patient will have a permanent tracheostomy or laryngectomy, whatever you want to call it. All right, now think about it, y'all. If they have removed your epiglottis, that means now that you have two tubes going up into your oropharynx, your trachea and your esophagus. So every time that patient swallows, they don't have an epiglottis, there's two tubes for food and fluid to go down. So they're going to aspirate every time. That's why they cannot leave your trach up into your oropharynx. They have to reroute it out your neck, right? So with a total, all of your breathing is done right here. And there is not another tube going up into your oropharynx anymore. All right? And we're going to talk more about that in just a second. Now, position post-op. What position would you put the patient in post-op? Remember, we had a surgery up here. Okay, I heard Fowler's, high Fowler's, mid Fowler's, low Fowler's. Which Fowler's is it? That's a lot of Fowler's. Well, I always say this. Pick the one that's sitting up the most, but don't pick high Fowler's. Hey, y'all. You know you've never seen somebody riding back from surgery sitting straight up in the bed riding down the hall like that. Now, have you? No. About mid-Fowler's is fine. Head of bed at 30 to 45 degrees is fine. Y'all, do you agree that with any surgery that there's always a little bit of edema? Yeah, but we don't want any edema up here because it's just too close to my airway. NG feedings to protect the suture line. Peristalsis can disrupt the suture line. Some books will say NG feedings because it hurts to swallow And I'm sure it does hurt to swallow. But what's more important, the pain or protecting the suture line? Protecting the suture line. Monitor the drains if they have any. That would just to prevent any fluid from accumulating up here. And watch for carotid artery rupture, which just sounds like a big problem, right? Right. Now, do you agree that due to the proximity of the carotids to the surgical site, there's a chance that one of them could become nicked? Yeah, during the surgery, okay? And so the patient's naturally going to hemorrhage. Now, another thing that we have is called the rupture of the innominate artery. Now, what if you walked in the room and you looked at the trach and it's pulsating ever so slightly in and out of the neck? Would you worry or not worry? Worry, or would you say, oh, look, your trach's pulsating? You worry, don't you? A pulsating trach is a sign of rupture of the innominate artery. It's a medical emergency. Just between you and me, is there a whole lot you and I can do for a pulsating trach? No. What you going to do for it? Hold it in place? No. You're going to call the doctor. You see, if there's nothing you can do to help the person, that's when you call the doctor. Now, let me ask you a question. What if it said on the test that you've got a pulsating trach? Which action takes priority? Call the doctor or check the vital signs? What would you pick? You better call the doctor, because you've only got one chance to tell the NCLEX people the most important thing you would do. But didn't check the vital signs sound good? Yeah, because in school, what do they tell you? You better check the vital signs before you call the doctor. The doctor's going to get mad. NCLEX people don't care if the doctor gets mad. It's saying, hey, new nurse, if you could only do one thing, now this is real NCLEX-y. If you could only do one thing, what is the one thing you would do here? Well, you better tell them, if you don't do anything else, I promise I'm going to call the doctor. Because if you check vital signs, you're telling the NCLEX people, okay, for a pulsating trach, that's the one thing I'm going to do, is I'm going to check the vital signs. Over and over and over again while you die, you see, okay? That's why that answer doesn't work there. If you use that strategy, that'll help you get rid of answers like check the vital signs and that sort of thing. When it says priority, you've got one shot at telling them the most important thing to do. And when you realize that NCLEX is about life or death situations, you'll pick the better of the two that way, by thinking like the NCLEX people think. Frequent mouth care to decrease the bacterial count in the mouth, and MPO people tend to get pneumonia anyway. Well, if they have a lot of bacteria building up in their mouth, that bacteria is going to travel down to their new trach site infection, or could it go all the way down to their lungs and cause pneumonia? Yes. So anytime you've got somebody that's MPO, you better be doing really good mouth care with a toothbrush and toothpaste. Not with a lemon glycerin swab. That doesn't help anything. That doesn't decrease any bacteria at all. A bib will be used because that acts like a filter, for one thing. And also there's a lot of body image changes when people have a trach, okay? And so they feel more comfortable. They've got products they can buy to cover the site. Now when you're selecting something to go over the trach, don't you think it would be important that air be able to move through it? Why, yes. But sometimes you're reading textbooks where it'll say plastic can be used. Now, if you select plastic on NCLEX to be placed over the trach, are you going to get a license in the mail? No, because you cannot breathe through plastic. And you don't pick things that have a lot of fibers on it either, because that'll irritate the trach, like a washcloth, that sort of thing. Keep powder and all that kind of stuff away from the trach too. That's going to irritate. Now, a humidified environment helps. You know, when you and I breathe in, we breathe in through our mouth and nose, so we are warming and filtering and humidifying the air that we breathe. When you're breathing in through here, you don't have a way to warm and filter and humidify, so the air going in is real dry, so it irritates the trach, and that's why when you first get a trach, it has lots of secretions. But as time goes on, the secretions decrease, and a humidified environment will help with that. Also, remember, with a total laryngectomy, all breathing is done through the stoma, and other treatments for laryngeal cancer, radiation, and chemo. Now let's talk about a trach for a second. Let's pretend that you are working the night shift. It's 3 o'clock in the morning and you decide you're going to do trach care. And you know your teacher told you that when you're changing the string, you're not ever supposed to remove your hand from here. You got to hold this in place, right? But you forgot. And your patient coughed. And the trach goes blowing out across the room like a missile and lands in the floor on the other side of the bed. Tell your friend how you would handle this scenario. All right, wouldn't it be great if there were a sterile trach just sitting at the bedside ready for you to reinsert? Wouldn't that be wonderful? But y'all, the answer you want is never, ever, ever going to be there. Now, is it? So what else could you do? Sterile Vaseline gauze taped down 3 sides? What you think? I don't think we're going to cover the airway up. Put your finger in it? No? What are you going to do? There's a thing, and this is on your handout to the side there. It's called an obturator, which is something that will hold the airway open until you can get a sterile trach there. Holds it open. You've got to put something in there to keep it open or it's going to collapse, you see. So if sterile trach's not there and obturator's not there, what else does that leave you to do? See, we've got to look for options on this test because y'all, NCLEX already knows what the perfect answer is in your brain. And you know that the perfect answer is to get a what? Sterile trach. Well, so the perfect answer is never going to be there. So what else can you do? If you know that it's going to collapse, if you wait much longer, you better run across the other side of the bed and pick up the trach, blow the bacteria out of it, and do what? Reinsert. You do whatever you have to do to reestablish the airway. Now you write that down. Reinsert the dirty trach. And that is going to tear you up because I know what you're thinking. Marlene, it's been on the floor. That is gross. They'll kick me out of nursing school if I do that, right? Right. Hey, would you rather be alive with an infection or dead without one? Now tell me what you'd rather have. Look at her. She's dead. But she's infection-free, right? No, that's not nice. You keep them alive and you reestablish the airway. And as soon as you can get a sterile trach in there, you get it in there, okay? Now, when you have emergency, a situation where you need an emergency trach, like with the burn people we were talking about this morning, that's when you use a trach. It's bigger around and it's a little bit deeper when it goes in. When people go home with a trach, they call it a laryngectomy tube then, all right? And a laryngectomy tube is just smaller around. It's the same thing as a trach. It's just got a different name. It's longer term, okay? You use it forever. It's smaller around and it's not as long, too. And, you know, there's certain types of surgeries where the patient can learn to put a finger over the site, okay, and let air come up into the oropharynx and they can talk. Or they've got speaking valves. Have y'all seen those? Speaking valves, they call it a Passamere speaking valve. That's just like a thing you put in here so air can move up into the oropharynx. But you got to have a trach going up into your oropharynx to be able to do that, right? Right. Now, anytime somebody's got a speaking valve in place, you stay in the room with them the whole time. Because if they ever get to where they can't breathe, somebody's got to be there to take it out, right? And the family's always real nervous about using the speaking valve, but they also want to talk to their family members. So they'll come in there and say, will you please put the speaking valve in? You know, and you're like, well, I can't yet because I'm busy tied up over here, but I'll be there in just a second. Let me ask you just a few more questions about total laryngectomies. Now, when I say total, what did I say that meant? That there's no trach going up in here. Everything's out. It's coming out here. So if I have a total laryngectomy, can I whistle? What do you have to be able to do to whistle? Pull air in, right? Okay. You can't do that. Can you drink through a straw with a total laryngectomy if you don't have a trach going up into here? Can you drink through a straw? Because you have to be able to form a suction, right? So it would be mean to go up to your little patient and say, now come on, drink your apple juice, right? Pull on the straw, Papa. Oh, come on. No, they can't. Could I smoke? If I'm breathing in and out through my neck, can I smoke? Not recommended, right? Now, don't get me wrong. You will see people at the casino smoking through their trach, okay? Now, that is not recommended, but I can still smoke through there if I want to. What if I have a total laryngectomy and I have been a world champion swimmer forever, and now I got a trach? Can I still go swimming? After, say, I've had my trach for 4 or 5 years and I'm really used to it, can I go swimming? Not recommended, right? Think about it. I'm breathing in and out through my neck. When I go over here and jump off into the deep end, what am I going to do? Drown. You're not going to get a license like that. Now, are you? No. And let me make you feel better. I have had people that went on to pass boards that said, yes, they can go swimming if they plug up their trach. Y'all, are you going to get a license in the mail if you go around plugging up people's trachs and putting stuff in people's trachs? No, you don't do that. Let's move on to something easy. Suctioning now. Do we use sterile or non-sterile technique? Sterile. Hyperoxygenate when? Before and after. Now, when do you stop advancing the catheter? When they cough or meet resistance. Either one. When they cough or meet resistance. Put a star by meet resistance. Now, don't get me wrong. They're going to cough too, and that is a sign you need to stop. But some people, you tell them you're about to suction them, and they start coughing, right? And the catheter hadn't even gone in yet. Now, apply suction when? On the way out. On the way out. And do we use intermittent or continuous suction? Intermittent. You are a mean nurse if you suction continuously, right? Don't be mean. And suction no longer than 10 seconds. And watch for arrhythmias, because which nerve can be stimulated? Vagus. And when the vagus nerve is stimulated, heart rate drops. Okay, so you're suctioning somebody and the heart rate drops. That's not hypoxia, because when you're hypoxic, what does your heart rate do initially? Goes up. So I know I've stimulated the vagus nerve. And if they become bradycardic, what do I do? Stop suctioning and do what? Hyperoxygenate. That's right. Stop suctioning and hyperoxygenate. Now let's look at colorectal cancer. Colorectal cancer may start as a polyp. 2/3 of colorectal cancer occur in the rectosigmoidal region. And the most frequent site of metastasis is the liver. Now, when you get into liver metastasis, that's when your patient is going to have a lot of bleeding problems, right? Yes, lots of bleeding problems. They're going to become jaundiced. They're going to start retaining toxins. They can't break down drugs. We're going to take bleeding precautions with that person, which we're going to talk about more later. Other problems to watch for: bowel obstruction. They can perforate. They can develop a fistula, which goes into their bladder and into their vagina. In other words, that cancer is eating away through internal organs. And risk factors: inflammatory bowel disease. Y'all remember on the first page of the oncology section, we said chronic irritation brings about cancer. Well, inflammatory bowel disease is inflammation and irritation, isn't it? Okay? Genetic predisposition. Chronic constipation. Well, if you have trouble with constipation all the time, you're retaining carcinogens. And, you know, the person I think about there is not only the elderly, but I also think about spinal cord injured people who do not have the nerves going to their intestines like they used to, so they tend to retain more carcinogens in their intestines. Dietary factors: refined carbs, low-fiber diet, high-fat diet, red meat, fried and broiled foods. Now, some people look at the broiled food and they say, oh, what's the deal with that? I thought that was healthy. Well, it is healthy, but you don't want to overcook. You know, it's the burned part that's considered to be the unhealthy, charred part, okay, that promotes carcinogens. That's why grilling on the grill is a good thing, but you don't want to do anything too much, because that charred part is what has the carcinogens in it, okay? And if you have a first-degree relative with colorectal cancer, your risk just increased 3 times the norm. So family history is important. And just because you've got somebody who's had cancer in your family doesn't mean you're going to get cancer. It means that if you do get cancer, you'll probably get odds are you'll get the same kind they did, okay? That's the which way you have to think of that. 95% of those who get colorectal cancer are greater than 50 years of age. Now, screening. Fecal occult blood testing should begin at 50. Flexible sigmoidoscopy every 5 years or colonoscopy every 10. The definitive test for colorectal cancer is a colonoscopy. Do y'all remember when Katie Couric had her colonoscopy on the Today Show? Y'all remember that? You know, her husband died of colorectal cancer, so then she went and had her colonoscopy on TV. And then what did she just have last week on TV? A mammogram. That's right. Okay. Now then, wonder what's next. Anyway, signs and symptoms. Most common signs are rectal bleeding, anemia, changes in the stool. Like you hear about people who they have diarrhea and then constipation, diarrhea then constipation. They say change in bowel habits is what they say. Other signs and symptoms, blood in the stool, vague abdominal pain, fatigue, abdominal fullness, weight loss. Anytime somebody has cancer and they start dropping pounds rapidly, unexplained weight loss, then that cancer's on its way. Because when cancer is growing inside the body, it really makes you burn, you're in a hypermetabolic state, right? So you're burning more calories. All right, may become obstructed. Now, with an obstruction, you may see visible peristaltic waves, and that just means when the patient's lying flat, you can see their abdomen rolling. It's just trying to push through that obstructed area with high-pitched, tingling bowel sounds. Now, treatment, surgery, radiation, or chemo. The drug of choice is 5-FU. They may have a colostomy, a colectomy, where part of the colon is removed, and with that, they may not need a colostomy. It just depends on how much got removed. And they may have a very radical surgery known as an abdominoperineal resection, and it's removal of the colon, the anal area, and the rectum. So it's a very radical surgery. Now, can you take a rectal temp on this patient? There's no rectum, so you can't take a rectal temp, right? Don't take rectal temps on anybody if they're thrombocytopenic, have had an abdominoperineal resection, or any form of immunosuppression. That is a rule. That is a nursey rule. Bladder cancer. The greatest risk factor here is smoking. The nicotine from the smoking irritates the lining of the bladder. Okay? Major symptom, painless, intermittent, gross, or microscopic hematuria. Now, since it is painless, that's one of the major reasons people do not seek health care, because, you know, if we're not hurting, they think we'll get over it, right? A lot of people think, well, I must have hurt myself some way, and they'll just go on bleeding. Diagnosis, they're going to do a cysto. And treatment, surgery, where they may remove all or part of the bladder. Now, y'all, sometimes they can just instill chemo directly into the bladder and kill the cancer, or they can go in there and just remove the tumors. It just depends on how advanced the cancer is. Well, if they remove all or part of your bladder, you may have what's called a urinary diversion or a urostomy, and a common urostomy is called an ileal conduit. Now, what they do there is they take a piece of your ileum and turn it into a bladder. You see, they took out your bladder because it had cancer. It's gone. They've gone over here to your intestines and taken out a piece of intestine and then re-sewed up your intestines. Now, they take that piece of intestine and that's your bladder. Now, they remember your intestine is shaped like a straw. Okay? So they plug into one end of the straw your ureters. Okay, and then the other end is brought to the abdominal surface as a stoma, and that's what they wear the bag over, and it drains urine continuously. They don't have any control over this, okay? Post-procedure, the patient may be impotent. Here's the deal. With any surgery of the reproductive or urinary tract in a male, there's always a chance of impotency, because do they cut nerves? Yeah, which we're going to talk more about those nerves later. There's always a chance. That's why it says maybe. Not everybody is. Hourly outputs. Hourly outputs. Y'all, it is a rule that anytime you've got somebody who's had a urinary tract surgery, you better make sure their urine output never drops. After a urinary tract surgery, you never want to decrease in the urine output. That is always a bad sign to us. We've got to increase fluids. They need to drink about 2,000 to 3,000 cc's a day to flush out the conduit. 2,000 to 3,000 cc's. Flush out the conduit. Now, is mucus going to be normal in this urine now? Yes, because what's their bladder made of? Intestine. And intestines always make mucus. Now, change the appliance in the morning time because this is when output will be at its lowest. Now, a lot of people think, well, the first thing I have to do when I get up in the morning is go to the bathroom. What's the deal with that sentence? Well, here's the deal. All during the day with this person, we've got them drinking a lot of fluid, right? To keep the conduit flushed out. So naturally, they're draining urine all the time into the bag, and they can empty the bag throughout the day. But when they've slept all night, they've gone all night without drinking fluid. So that's why output's at its lowest in the morning. That's when you want them to change their appliance and do their skin care around the stoma, because do you want urine draining everywhere? No, that's going to irritate the tissue. And it says on your handout that it is okay to place a little piece of 4x4 inside the stoma during skin care to absorb any urine. Just don't forget to remove it, right? You never want to put anything in the urinary tract to clog it up, all right? Because if urine can't come out, that can cause renal failure when it's backing up. That's why earlier when we were talking about in the burn section, those cells breaking down, clogging up the kidneys, urine can't get out freely. On the next page, prostate cancer. This patient comes to the doctor with signs and symptoms of benign prostatic hyperplasia. Signs and symptoms like hesitancy, frequent infections. You see, people with prostate troubles, enlarged prostate, with an enlarged prostate, they have frequent infections because are they able to empty their bladder completely? No, so they have stagnant urine in the bladder. Nocturia, that's the one that irritates them the most. Waking up every 10 minutes, having to feel like they have got to go to the bathroom. And their wife is saying, you just went to the bathroom, but they have an urgent need to go to the bathroom because they're never emptying their bladder. Urgency and dribbling. Now, the most common sign is gross painless hematuria. Well, see, the patients having all these symptoms that we have, they may or may not have the painless hematuria. But even if they have the urgency and the nocturia and all that, they're going to go to the doctor. The doctor's going to do a digital rectal exam. That's the first thing they're going to do. And the prostate may feel hard or nodular. Or the doctor during the prostate exam may feel one little nodule. That's still not normal. If you feel anything that's nodular or hard in the prostate, that usually means cancer. So they do more investigation, diagnosis, lab work, check your PSA, prostatic-specific antigen. This is a protein that is only produced by the prostate. Normal is less than 4 nanograms per milliliter. And if you have 2 or more first-degree relatives with prostate cancer, you need to start PSAs by at least age 45. All males with their routine yearly physical exam might as well go ahead and start getting a PSA drawn. It's a blood test. And keep up with it. Now, the thing is you're looking for changes in the PSA. You can have a PSA who is still within normal limits, but it's elevated from the last time, and that could mean problems, okay? So it doesn't have to be way out of whack to be abnormal. That's why it's important that everybody keep up with their PSAs. Also, alkaline phosphatase. If it's increased, that means bone metastasis. And that's with any type of cancer. They'll check the alkaline phosphatase, and if the alkaline phos is up, that means bone troubles, okay? Now, prostate cancer in particular likes to go to the spine, the sacral area, and pelvis. Normally, when you have somebody presenting with prostate troubles and they're having bone pain, that's late. And as you know, that's a late sign. And bone pain, bone cancer is one of the most painful types of cancers in the whole wide world. Another test they'll look at with any prostate trouble is the increased acid phosphatase. Biopsy. When prostate cancer is suspected, a biopsy must be done for confirmation prior to surgery. Now, different ways to treat it. One way is with watchful waiting, they call it. You know, if you're already 82 years old and they tell you you've got prostate cancer, a lot of people just choose to do nothing. because it's such a slow-growing cancer anyway, and the treatment can cause a lot of other troubles too, can't it? So that's why they just say, in some people, watchful waiting. In early stages, it's for asymptomatic older adults with other illnesses. So the treatment could make their quality of life even worse. They may choose not to do anything. Other people, they do surgery like a radical prostatectomy, and that's done when the cancer is localized to the prostate. That means they can go in there and take out your prostate and you are cancer-free. All right? Now, they may have erectile dysfunction due to the pudendal nerve damage. They can also be incontinent. That's why we have to teach the Kegel exercises. And some people, after they've had that radical prostatectomy, have to wear a urine drainage bag from now on. And then you can get into other surgeries where they can go in there and do different things to control the urine flow, but that's getting into really detailed types of surgeries. The patient is sterile, okay, because the semen is not going to be coming out like it used to. This is where your teacher taught you about retrograde ejaculation, that sort of thing. And if there's no lymph node involvement, no increase in the acid phosphatase, and no metastasis, the surgeon will try to preserve the pudendal nerve. Now, you may be thinking, well, why wouldn't they try to preserve it anyway? Because if they're not feeling comfortable, they don't want to take a chance of leaving any cancer in there, is what I'm saying. And that might be the payoff for being cancer-free, is having damage to that nerve, all right? All right, now, look at the next thing we have. Prostatectomy. Another type of prostatectomy is called a TURP. Now, why am I going to talk about that here? Because a TURP is the most popular prostate surgery in the country. This is the main type of prostate surgery we see, so that's why we got to talk about it. It's transurethral resection of the prostate, and it's usually reserved for BPH to help the urine flow. You know, your prostate is shaped like a donut, okay? And the urethra runs through the center. So if the prostate swells, it clamps off the urethra so urine cannot get out, and that's why the patient becomes so symptomatic, all right? Now, the reason it's so popular is there's no incision, okay? They go in through the urethra. Most common complication, bleeding. Don't get me wrong, they are going to bleed. Bleeding is normal. I'm talking excessive bleeding here. With other procedures, you have to explain the risk of impotency and infertility, because with other procedures, they do have a what? Incision. With other procedures, they have an incision, which could damage the nerves. And is it normal to see bleeding after this surgery? Yes, but I'm still worried about it, because can bleeding clog up my kidneys? Yes, that's why we've got the continuous bladder irrigation. To maintain patency, flush out clots. If you get clots in the urinary tract, you might be about to have renal failure too. You got to have a special catheter, a 3-way catheter, and you never want kinks in the tubing. If that drainage tubing gets kinked up, then the urine can't drain out, and would that cause pressure on the suture line? Yes, that can mess up the entire surgery. Now, you have to subtract the irrigant from the output. See, urinary tract surgery here, y'all, you got to keep up with the output, don't you? Because we're so worried about kidney damage. But you're putting a lot of irrigant in with this urine to keep the clots flushed out. So you've got to keep up with how much irrigant you're putting in so you can subtract it to know what the exact output is, right? How are you going to know how the kidneys are working if you don't know the exact output? Rule: never hand or manually irrigate catheter with fresh surgery without a doctor's order. Y'all, do you agree with any fresh surgery that you shouldn't be messing with tubes like NG tubes and catheters and irrigating things, that sort of thing? Yeah, the surgery's still in too fragile a state for a brand new nurse to be fooling with it, okay? All right, now what drug do we give for bladder spasms? Well, one's a B&O suppository, another one's diazepam. Let's pretend that we've got a patient who's had this surgery and they're on the call light hollering for you to get in there because they're having bladder spasm, bladder spasm, bladder spasm. They're hurting so bad, hurry up and get that suppository. So you go in the room. What do you assess first? The tubing for kinks or the bladder for distension? Ask your friend. I know what you're thinking. You're thinking you're going to check both of them, aren't you? Yeah, we hate to pick between answers like that, but NCLEX loves to put you in a bind. That's what NCLEX is all about, is putting you in a bind, making you pick between two things you don't want to pick between, because you know you do both of them, right? Well, here's my strategy here. Always assess prior to selecting an implementation answer, and always assess the patient first. So bladder distension would be your answer. That's the patient, isn't it? Bladder distension. Y'all, if you're not getting all my scenarios right, don't worry about it. That's why you're taking the class, right? Believe me, we got lots more scenarios to go through. And if I gave you scenarios all week that everybody got them right all the time, what would you leave here thinking? I am good. I didn't need that, okay? Well, you need to be challenged while you're in here. It's better to be challenged now than at the computer. Now, when the catheter is removed, what do you watch for? Retention, urine retention. Because you know when you've had a catheter in for a while, things just don't always kick back in and work like they're supposed to, right? So watch for urine retention. Temporary incontinence is expected. That's why we encourage the perineal or the Kegel exercises. The patient needs to avoid sitting, driving, strenuous exercise. Don't lift too much. Any of that can make you bleed. What's Colace? Stool softener. They don't need to be straining. Straining will make you bleed. They need to increase fluids to flush blood out. To flush out the blood. Because could that blood make a little clot and clog up your kidneys? Yes. They can also do, for other prostate cancer, they can also do, now before I move on, let me clarify something. I talked about a TURP right in the middle of all this, okay? You do not have to have had prostate cancer to have a TURP. There are people in the world that just have prostate hyperplasia, and they do a TURP to relieve their symptoms, okay? But sometimes, say you've got prostate cancer and it's already metastasized out in different places, they may do this as a comfort measure so your urine can come out more easily. Does that make sense? A TURP is not going to cure prostate cancer. It's just it's symptomatic relief. Other treatments for prostate cancer, radiation, chemo, and they can do hormone therapy. And one thing they can do is a bilateral orchiectomy to decrease testosterone. They can also give estrogen to fight testosterone. And they can give Lupron. Lupron in the male will decrease testosterone. And last but not least, stomach cancer. All right. Risk factors. Well, H. pylori has been associated with it. They won't say that it's a cause, but it's been associated with stomach cancer. Also, there's a higher incidence of stomach cancer in people with pernicious anemia and achlorhydria. That's when you don't have any acid in your stomach. No acid in your stomach. It's also related to eating pickled foods, salted meats or fish, nitrates, increased salt, or the surgery of Bill Roth 2, which is a partial gastrectomy, like if you had a bad peptic ulcer and they went in there and took out part of your stomach and they reanastomose you, that can cause atrophic gastritis. And then also other risk factors, there's that tobacco and alcohol again, especially in the presence of each other. Remember I said they act synergistically. They're co-carcinogenic. Signs and symptoms. Most common, heartburn and abdominal discomfort. Other signs, loss of appetite, weight loss, bloody stools, coffee ground vomitus. John just tells us who's gotten into it. The liver's in it now. We've already got some metastasis. Epigastric pain, back pain, a feeling of fullness. You'll see people that present saying, you know, I'm hurting a little bit right there, and I can eat 3 bites and just be full. Well, that's because the tumor is taking up part of their stomach, right? Yes. All right. Also, anemia, stool may be positive for occult blood, achlorhydria, no acid in the stomach, or you can become obstructive. With any GI stuff, y'all, you can get an obstruction. The most common signs of a GI obstruction are abdominal distension, nausea and vomiting, pain. And normally what they do is they'll make you NPO right then. Put that on your handout. NPO, and put an NG tube down and hook it to suction for decompression. Now, other ways they diagnose stomach cancer is with the upper GI, a CT, or they may do an esophagogastroduodenoscopy. In other words, scope you to see what's going on in there. Treatment. The preferred treatment is going to be surgery, gastrectomy. Now, y'all, that might be a curative surgery. If they can take out part of your stomach and you're cancer-free, great. But more than likely what they're doing here is debulking the tumor. Now, when I say debulk, I just mean taking out all they can, right? Because normally with gastric carcinoma, it's what they call an adenocarcinoma. And when you have an adenocarcinoma in one part, you probably got it in other places already. It just may not have presented itself yet, okay? So what they'll do is they'll debulk the tumor, but try to leave you a little bit of a stomach, like a 30cc pouch, so you can still eat and drink with some degree of normalcy, okay? Now, post-op, Fowler's position. In other words, you're sitting them up a little bit to decrease stress on the suture line. They will have an NG tube for decompression. And is it okay to reposition that tube? What if it stops working on you the first 24 hours post-op? What should you do? I just told you a minute ago, fresh surgeries. Leave it alone and call the doctor. You don't mess with fresh surgery tubes. They're afraid we'll disrupt the suture line. That's what they're scared of. Afraid we'll disrupt the suture line. Now, don't get me wrong. When somebody comes back from a gastrectomy, they're going to have the NG tube down and hooked to suction. But remember, I said I just had a little 30cc pouch. It's going to bleed in there some. It's fresh surgery. So do you want a lot of blood accumulating in my little pouch? No, it's going to rupture my stomach, you see. That's why you watch the blood, but don't you mess with that tube. It's too fresh. All right, now, two major complications of a gastrectomy. Y'all, there are other times or other people that get a gastrectomy too. Like if you've had gastric bypass or something like that, you can get these same problems. All right, well, one complication is dumping syndrome, which we're going to talk about more when we get into the GI system. And then another complication is B12 deficient anemia, known as pernicious anemia. Okay? So see, at the top of the page, I said that pernicious anemia can be a risk factor for getting cancer, right? But if they, another way to look at it is if they take out your stomach, now you're going to get pernicious anemia. All right. Now, one way they diagnose this is with what they call a Schilling's test. And this measures the urinary excretion of vitamin B12 for diagnosis of pernicious anemia. The Schilling's test will only tell you about pernicious anemia. It will not tell you about any other type of anemia, like iron deficient anemia. If they put that Schilling's test on an iron deficient question, you would not pick it. It only goes with pernicious anemia. Now, here's how pernicious anemia works. Well, they took out your stomach, didn't they? Yeah, no stomach, no intrinsic factor. If you don't have intrinsic factor, you cannot absorb oral B12. And I said oral B12, right? And if you can't absorb oral B12, you cannot make good RBC, so you're going to become anemic. How do you feel when you're anemic? Tired and your heart beats fast, pale conjunctiva, you know the signs and symptoms of anemia. Now, what they will do here is this. I said the patient cannot absorb oral B12. So what am I going to have to take? B12 shots. I can absorb IM B12. So they're going to give it to me probably the B12 shot I'm talking about, every week for a month, and then like monthly after that. They'll give you the B12 shot every week for a month, and then monthly after that. All right. Now, other treatments for stomach cancer, chemo, and I've listed for you some common drugs there, and then they can also do radiation. It just depends on the type of cancer that you have. All right. That concludes today. Y'all made it through the first day. Thank y'all for coming.